consent form. So there will be a consent form when you're testing out. We give that to the patient. Okay? I'm going to have you sign this consent form. We have that done. Next, I want to make sure that the IV is patent in the patient. What is the only IV solution compatible with blood?
Normal saline.
Normal saline. So I will have different ones here. Saline, dextrose, heparin. Got to grab the right one. So this is one of those test outs where you don't have to follow everything in the exact order till you're actually doing the blood. So you can choose to hang your saline and make sure it's running, which I would do, because if the IV is no good and you brought the blood up, you only have 30 minutes to start that transfusion. Okay, so I'm going to hang my saline right now, and instead of, we're not going to prime anything, we're just going to tape it up so that we're not going to puncture these bags at all. Okay, the tubing for a blood transfusion is a Y-set tubing, just like similar to the peritoneal dialysis. It's a Y-set. One is for the saline and one is for the blood. I'm going to close both clamps, and we're just going to tape them up here, and then I'm going to say that my saline is infusing, and we can leave it at a KVO rate. KVO stands for keep vein open. It's about 30 ml per hour. That's all it is. Okay, so I'm going to tape it up here, and I'm going to open my clamp a little bit, prime my line. You can't squeeze the drip chamber, but there's a filter in here. Running this, priming the line, close the clamp, okay, and then I'm going to, that's as far as we're going to go with that, okay? You don't have to connect it to the patient, okay? So I'm going to keep it at a KVO rate, the saline. Blood bank call says the blood's ready. I take my little slip, and each of you have a different blood on your slip, and you have to grab the right type of blood. So that's the next step. Okay, let's say it was B negative. I grab B negative, I come back up, I need a second nurse. I'll be your second nurse, I'll hold that slip then, and you're going to read everything to me. Caroline Brown, date of birth 5/1951, medical record number 579-451-7569. It expires 8/2025. The unit number is 0062385. Okay, so 1, 2, 3, 4, 5, 6 things that you're going to read off. We inspect the bag of blood to make sure it's not bubbling or leaking. If it's bubbling, it's expired. Okay, it says how many ml are in the bag. It's 300 ml. So you'll have to tell me what rate you'll run it at. And you can choose if you want to run it on a pump, you'll tell me ml per hour. If you want to run it by gravity, you can tell me that as well. Okay, so we're going to run the blood over 2 hours. So once we've checked together, we both sign the blood. And now, this is probably the hardest part of the whole thing. Both clamps can't be open together. We never run them together. They're compatible, but we don't run them together. Okay, I have checked my vital signs. Patient was still stable. Okay, and now I'm going to tape this here. This is me priming. I close the clamp, and now I'm going to open the clamp for the blood. Okay, and now I have to sit with the patient for 15 minutes and monitor for reactions. The most serious would be hemolytic reaction. If the patient had back pain, that would tell us, or they're short of breath, that would tell us hemolytic. They could develop an allergic reaction, so they can have shortness of breath, or they can develop a rash. The third one would be like sepsis or bacterial type of infection. They could develop a fever, flu-like symptoms, so that could be similar to the allergic reaction as well. The fourth one's not really a reaction, but fluid overload. Depending on the age of my patient, if the doctor wanted this in 2 hours and he's 80 years old, I'm going to double check with the doctor. Do you really want it to run that fast? Okay, so I can disconnect from my patient now, because I'm not going to sit here for 15 minutes and watch saline go into the patient, and I can't open it wide and just rush it in. So I'll disconnect, and over the garbage, I'm going to run this until the blood gets to the tip right here. Once it's to the tip, I'm going to clean the site, hook it back up to the patient, okay? And now we run it at 50 ml per hour for the first 15 minutes, because for 2 hours, this really is going to run at 150 ml per hour. 50 ml the first 15 minutes, I stay here. Can I have a UAP, a medical assistant sit at the bedside for the 15 minutes? No, because they cannot assess a patient, all right? They cannot assess, so that has to be me. So I started at 50 ml per hour. I'm sitting with the patient. 15 minutes go by, the patient's fine. I'll do another set of vital signs. Then I'm going to set it to my rate of 150 ml per hour. Saline is off, and then it's policy, whatever the policy is for how often you check. Every 15 minutes for the first hour is pretty standard, and sometimes for the second hour, every 30 minutes. If I feel my patient requires more frequent, I can still do it every 15. It's nursing judgment at that point, okay? So we'll say that the blood transfused, the 2 hours was over, I come back into the room, the bag is empty, I'm going to close off this, and now I'm going to infuse, just really flush some saline through to clear the line, okay? If the patient's gonna get a second unit of blood, I can keep this back to KVO or 30 ml per hour saline only, just to keep the line open. And then when I go get my second unit of blood, this all comes down, new tubing, just like TPN, every 24 hours new tubing, but with blood, new tubing with every new bag that you hang. If they are not getting any more blood, I'll just flush the line a little bit, disconnect, and I can toss. This has to go in a red bag. Okay? And I'll do a final set of vital signs and make sure the patient's okay, and that's it. Some questions that come up on NCLEX, can the patient ambulate while they're getting a transfusion, or do they have to stay in bed?
Stay in bed?
They can get up. They can get up with the blood transfusion. Okay, and again, fever is the most important thing. We're watching for a spike of more than 1 degree that we notify the doctor for. Now, if he has some kind of anemia and he's gotten multiple blood transfusions, okay, and sometimes they develop, there's antibodies, you're getting someone else's antibodies. You could develop autoimmune disease from blood. Hepatitis and AIDS are really, it's filtered since 1985, so your chance of getting those two diseases would be, it's a 1% to 2% chance. But you're getting someone else's antibodies, so you could be spiking a temp. Someone who's gotten frequent transfusions, if they're known to have symptoms like temperature goes up or a rash, and it's ruled out that it's not to the blood, the doctor will order pre-medications. It's not for someone getting their first transfusion. It's someone who gets them once a week, once a month, or whatever, for whatever condition they have. The pre-meds would be Benadryl, corticosteroids, and Tylenol. Because the doctor knows that patient and knows, he always spikes a temp, but we've ruled out that it's the blood or anything. So pre-meds are a special situation for someone who's gotten multiple units of blood. Okay, and that's it.